Okay, hi guys. Welcome back to another tutorial. Firstly, thank you so much for showing so much love to the HPLC videos. And we are now 800 plus subscribers, something that I had not envisioned when I had started this small discussion thing, attempt on discussion of pathology topics in 2020 around May end or June. That is when I started it, and we have reached a very strong 800 plus subscribers now. So thank you so much for that, and I hope I keep making videos which will help you in appearing in the pathology exams as well as even in your routine daily practices. As you all know, I alternate my videos between hematopathology as well as cytopathology. And once I'm done with cytopathology, most of the topics, then I'm even going to start histopathology. So for today, this was one topic which I had left incomplete because I had, after doing the hematology thalassemias, I had then continued with HPLC because I thought that would be a topic which needs to be done in continuity rather than me breaking it up. Hence, after dealing with this mainly the small round blue cell tumors in pediatrics, the soft tissue and mesenchymal tumors, I had not dealt with the epithelial tumors, although very far and few in pediatric cases, but you do come across epithelial tumors. So what I'm going to do is just show you a few tables today, because images you have are a big the image thing is a bigger problem. The microscopic image is a bigger problem in small round blue cell tumors, and I've already discussed that. Epithelial tumors in pediatric population are, as I said, very few. So I'm just going to show you a list of both few mesenchymal, few small round blue as well as epithelial tumors, and in the table, as I keep telling you the names and the differentials, I'm going to tell you a single point or couple of points or special tests which you can do, which are the answer for you to differentiate between the origin of the tumor. Since this is cytopathology, we all know that we cannot give 100% definitive diagnosis. We can only give a differential and then confirm it by molecular on the material and uh, ancillary investigations on the material available in FNA, or the best thing is to advise a histopath diagnosis where the staging can also be done. Okay, moving on. Of course, I have no conflict of interest, no monetary gains from any of my videos. I have not, made them for that. And I always reference what the sites that I take the images from, because what I'm talking to you is my own experience. I share that, or what I studied when I was an MD, or what I study till when I'm looking at a case, research papers, etc. But the images, yes, are not all of them are my own, so I reference them. So the tumors left were renal, hepatic, CNS, germ cell, trophoblastic, gonadal tumors, and malignant melanoma. Now, starting from this point, renal tumors are not very, very common, but they are not very rare either. They are rare. Compared to a Wilms tumor, you are not going to get other renal tumors as commonly in a pediatric population. I had, when taken Wilms tumors, told you the importance of nephrogenic rests, which are now being touted as the predecessors of Wilms tumor, intralobular or perilobular. And we need to differentiate between a nephrogenic rest and a Wilms tumor when a sample comes to you. I have discussed that in the first part. Hepatic tumors, hepatoblastomas, are quite common. Vascular hepatic tumors are also common. CNS medulloblastoma, small round blue cell tumors, ATs, RTs, that is rhabdoid and atypical teratoid tumors, they you do get that in pediatric population. Germ cell and trophoblastic tumors are one of the most common tumors which you come across in adolescent age group, in young adults, in and in pediatric population. If we go beyond the small round blue cell tumors, malignant melanoma is of course rare. Okay, coming to the age-wise distribution of different types of tumors. So in infants, that is less than 1 years, you get nervous system tumors, leukemias, and CNS tumors, sympathetic ganglia, paragangliomas, etc. So tumors arising from the ganglia, that is common. Then you will get leukemias, that is common in any age group, and of course CNS tumors is common in infants less than 1 years of age. Other tumors retinoblastoma, renal tumor, germ cell, soft tissue sarcomas, lymphomas, and bone tumors. Now, one important thing here, the germ cell tumor, I use the word young adults. So it is more common in children, like, above 10 years to 18 years of age group. If I'm going to show you the pattern wise distribution of each diagnosis. If you are getting those cells, then what should be your DD? And then I'm going to tell you a point as to how to differentiate between those tumors. Moving on, that is going to come later on. Young children between 1 to 4, again, leukemia, CNS tumors. Here you see that renal tumor has come up. And the ganglia tumors, the sympathetic nervous system tumors like paraganglionoma, etc., they go down. So less than 2 years, you're going to get more chances of paragangliomas and neuroblastomas and things like that. 5 to 9 years, again, CNS tumor has maintained its propensity. Leukemias, lymphomas become more common, and renal tumors, etc., go down. Older children, leukemias, lymphomas, CNS tumors, rest other tumors are always there. Adolescents, see, as I told you, you see that germ cell tumor makes an entry which was not there up to 10 years of age. So this is from a paper. This is not given in the textbook. So you can't quote. You can quote it in a conference or in your practical wo, but you cannot quote it, or maybe in a viva if you want to discuss it with your person who's taking the viva. You want to tell them that you've read it somewhere, fine. But this is not to be quoted in your exam papers when you're writing the paper. So in a paper in pediatric FNACs, what the author saw was, I've referenced the paper in the end. It's a good paper. When she compared the pediatric lesion sample from head and neck and versus the abdomen and the pelvis, which are the common areas, then in head and neck the lumps were mostly superficial. They were guided FNAs, mostly lymph nodes, and mostly benign. While in abdomen they were mostly malignant, solid organ lesions. Of course, they were image guided and deep seated. So the first 2-3 points are fine. The 2 points, of course, in abdomen it has to be deep seated mostly, except their parasitic cysts, etc., which are superficial, and you have to do it image guided. What is more important is that in abdomen you get solid organ masses more commonly as compared to lymph nodes. Having said that, it's not that you don't get a lymphoma in the abdomen. And secondly, they are mostly malignant. Having said that, it's not that you don't get a TB in the mesenteric lymph node. Okay. Now is the most important. Supposing you perform an FNAC, be it an abdominal or a cervical or an inguinal or any mass anywhere in the body in a pediatric population. If you are getting necrosis, inflammatory infiltrate in the background, and then you have to differentiate whether it is that cheesy curd-like thick eosinophilic caseous necrosis or serous purulent material ekdam pink eosinophilic homogeneous background suppurative necrosis. Are you getting eosinophils? Are you getting some membrane fragment which is common whatever I'm saying I've already taken before. That is why I'm not showing the images right now. Which could be a parasitic fragment, or is it TB ka caseous necrosis or cold abscess, where you look for scattered epithelioid cells, degenerated cells, or maybe a granuloma. Then, coming one by one, if it's an acute suppurative lymphadenitis, that is bacterial with suppuration, you will get karyorectic debris. You might also get karyorectic debris in something known as Kikuchi's disease. But in Kikuchi's disease, you won't classically get any neutrophil. There will be necrosis, debris, and other inflammatory cells. It could be just a bacillary infection where in the background you might get some bacteria also with polymorphs, with macrophages, some hemophagocytosis might be there on a background of necrosis. You might get degenerated epithelioid cells, polymorphs, and caseous dahi jaisa curd-like necrosis in the background. So these are some of the DDs of inflammatory lesions. Langhans cell histiocytosis can also give you an inflammatory kind of a smear, but that will be rich in slipper-shaped, long epithelioid kind of cells, macrophages, a lot of macrophages, and you might see grooving in the nucleus of those cells. And a background population of few to fair number of eosinophils should point to a diagnosis of LCH rather than TB. Hodgkin's always confuses with a granuloma. Anaplastic large cell lymphoma will look like a reactive lymph node where there might be some inflammatory cells. you have to look for atypical cells with eccentric nucleus, something like this. This is my experience. That's what I'm sharing with you. With maybe cytoplasmic vacuolation, or you look for something called as the florid cells, or you look for something with horseshoe-like hallmark cells in the FNAC that you do. If you are getting a granuloma on a background of polymorphs eosinophils, not that much necrosis, you have to look for something known as the Reed-Sternberg cell. It must be there somewhere. Okay. If you get back-to-back granulomas without too much inflammation, just a reactive polymorphous background, apart from TB, think about sarcoid in a female especially. Okay. Again, now coming to the next category, that is epithelial or epithelioid. So hyperplastic thyroid nodules, when there's too much hyperplasia, when the cells are actively making thyroglobulin and thyroxine, the hormone thyroxine, when you do an FNAC, you might get those benign follicular epithelial cells that are round with that pale cytoplasm in clusters, which differentiates it from a lymphocyte, because lymphocytes never come in clusters. uh, um, um, as well as you might get epithelioid looking cells in the background. There are thyroiditis, which confuses with TB, where you get inflammatory cells, epithelioid cells. Then you have to look for the fire flares, which you all studied in your MD. You can refer to Orell's or Grace for the image. Okay, then there are salivary gland neoplasms like pleomorphic adenoma. You get plasmacytoid cells, sometimes epithelioid cells with a lot of myxoid kind of a background. Fibroadenomas, again, you'll get the history, you'll get those staghorn pattern. Pilomatricoma, I have published, in our department, we've published a case where we thought that it was a small non-blue cell tumor with giant cells, and we were thinking of all the mesenchymal lesions on FNAC. Few epithelioid kind histiocytes were there, but it came out to be a pilomatricoma on histopath. So we got confused with giant cells and few small round cells, because pilomatricoma has a lot of ghost cells, and those ghost cells are very difficult to extract on FNAC. So what came in my needle was those intermediate cells and the giant cells, which were a reaction to the keratin. So that became a problem for me. And we you know we in when we gave the cytopath report, we were thinking it will come out to be a mesenchymal lesion. However, on histopathology, it came out to be a pilomatricoma. So that was a learning lesson for us. Then benign and malignant hepatic neoplasms can give you epithelioid cells, epithelioid sarcoma, Aral type carcinomas. Cystic, when you get a lot of cyst macrophages, if it's a midline swelling, think of some sort of a thyroglossal cyst. Then you look for some thyroid element, some other columnar cells or epithelial element. Branchial cyst in the lateral region, again look for columnar cells, some other epithelial element. If you're getting it in thyroid FNAC, then it could be a colloid filled cystic lesion of the thyroid, not a tumor. Okay, then of course lymphangiomas, a lot of pinkish material with cyst macrophages. Vascular lesions will have hemosiderin-laden macrophages and blood. Ganglion, again you might get synoviocytes. Rhagocytes are very common in synovial fluid, and then there are also cells of the synovium with inflammatory cells and cyst macrophages. Clear cells, perivascular epithelioid picomas will give you, I show you the images, cells with clear cytoplasm. RCCs will have clear cytoplasm. Hemangioblastomas, xanthogranulomatous pyelonephritis, you get cyst macrophages. You can appreciate that those are macrophages with necrosis, sorry, with inflammation. Lipomatous, you might get a lipoblast at times. If you're looking at the lesion, you might get hibernoma-like cells. Then clear cell tumors of the kidney. Then comes the spindle cell. Now all the cells will be spindled, of course. What differentiates is the origin, the clinical history, where the tumor is located, and of course you can perform ICC if you want. So like in spindle cell, you're getting nodular fasciitis or fibromatosis. Both will give you just spindle morphology. So you have to go for histopath. Uh, Spindle cell sarcomas like rhabdomyofibro. In a rhabdomyo, you might look for a rhabdomyoblast with cytoplasmic, like if it is a eccentric nucleus, and here is the nucleus and ugly looking nucleus in a spindle cell. Then you might, in a spindle cell variant of the rhabdomyosarcoma, you might look for cells with striations in the cytoplasm. if it's a very good stain section, then you might get a hint, okay, this is from the muscle, not just a fibrosarcomatous kind of a tumor. Small round I've already taken, so I'm not going to discuss in detail. See, again, the matricoma is mentioned here also. Why? Because we got this thing. We got small round cells and giant cells, and we got confused, and we made it a mesenchymal lesion. Actually, it was an adnexal lesion. Large cells, again, osteosarc, rhabdomyo, alveolar soft part, germ cell tumors have large cells. HCCs, granular cell tumors, Langhans cell and Now, all of this ICC on cell blocks or material that is there in the FNAC is very, very upcoming, and people do it now. Osteosarcoma, if you get a large cell, you might get eosinophilic osteoid in the background. Rhabdomyosarcoma, look for rhabdomyoblast. Germ cell tumors, a little difficult to catch. You might need to go for the radiological correlation. In fact, you should go for the radiological correlation in all of these cases with what is the clinical situation where the tumor is located. Malignant melanomas, look for melanin pigment, coarse brown, dark colored pigment, and special stains for melanin can be performed. Hepatocellular carcinomas, look for maybe some hepatocytes, look for transgression of the endothelial vessel in the cluster of hepatocytes, or endothelial cell wrapping, that is a vessel wrapping all these malignant cells in a HCC. Of course, there's granulomatous inflammation and Langerhans cell histiocytosis, as already explained. Then all this over here, Wilms tumor, neuroblastoma, rhabdomyosarcoma, all I've given you the different types of cytomorphology. I've given you the IHC over here, and of course the molecular, which you need to remember, which is important. Again, these are images. See, the clear cells have this kind of clear cytoplasm. Spindle cells will have spindle cell sheets. You can perform IHC to see what kind of material is there. And there is this kind of a indentation of the nucleus and small round blue cell tumors. Lymphomas will give you lymphoglandular bodies in the background. This is a medulloblastoma. You might get these rosettes in medulloblastoma. So these are things that you need to look for in a tumor. Again, these are clear cell. This is a Schiller-Duval body. So this is more of a germ cell. You'll get evacuation and these pleomorphic nuclei or maybe clear cytoplasm, and then you correlate with the radiology. Then this is a spectrum of the small round blue cell tumors I've already taken. This is the article that I was talking about. And these are my references. Hope this helped you, and you can always message me any questions that you have on the messenger. And since this is becoming too long, so I'm going to stop here, and I'll see you next time with a hematopathology video. Thank you.